Hello and good morning or good afternoon, everyone. I'm Bethany Hamilton of the National Center for Medical Legal Partnership. We welcome you to our webinar today. Today is June 8th, 2022. Time on the East Coast is 2 p.m. We're running for about 90 minutes today. You are joining us. We are partnering NCMLP and Health Outreach Partners on a HRSA-funded webinar, the unique role of MLPs in helping health centers address disability and chronic disease discrimination. This is the fourth of our four-part webinar series. And if you have been with us through all of the webinars, you know that we have been building up to finally be able to talk about how to build a disability and chronic disease MLP. Let's go to the next slide. As mentioned, the National Center for Medical Legal Partnership and Health Outreach Partners are utilizing our HRSA National Training and Technical Assistance funding to provide this training and technical assistance resource and experience for you. We want to thank HRSA for supporting our efforts on this webinar series, as well as the office hours where you can gain some more one-on-one TA support with our consultant, Katie Hathaway. Next slide. All right, so you are, as you have been, joining us on Zoom webinar. Everyone is on mute by default as they join this webinar. If you do have any questions, we are asking that you please utilize the questions and answer pane in that function. If you hover over your Zoom platform, you'll see Q&A, like two chat boxes that are, or quote boxes that appear. Hover over that, click on it so that you can type your questions in. That's where we'll be paying most attention to the questions that come in, so that as Katie moderates the Q&A, we'll be able to address those questions first. But please also feel free to utilize the comments if it's activated on your Zoom so that you can engage with each other. If you cannot see the ASL interpreters, make sure that your view is set to side-by-side gallery. So if you go to the top right of your Zoom platform, you'll see a view option appear. Click on that and you'll be able to change the view to side-by-side gallery settings so that you can see our ASL interpreters today. They will remain on the screen throughout the duration of the webinar. To activate captions, select live transcript and show subtitle. And we know that everyone will be asking, yes, this webinar will be recorded. The slides will be shared. You will be able to find it on the medical-legalpartnership.org/resources website, as well as on Health Outreach Partners website. A follow-up email will go out where you will receive links for that information forthcoming. Let's just allow the video to render and we'll be sure to post it as soon as we can on our websites. If you have any questions or need assistance during this webinar, you can email us at ncmlp@gwu.edu for assistance. Next slide. I'd like to, before passing the mic on, really sincerely thank Attorney Katie Hathaway, who's been our trusted consultant throughout this entire series. She's helped us to brainstorm and develop and deliver this webinar series, and we sincerely thank her on behalf of the National Center for Medical Legal Partnership and Health Outreach Partners for bringing her expertise in disability rights as an attorney who worked for 17 years at the ADA, the American Diabetes Association, to help them build and lead their legal advocacy program. So she's brought her expertise to this webinar series and helped us to recruit also an amazing group of Mlp practitioners to present on today's webinar. Katie, I'm going to pass the mic over to you for introductions and helping us to wrap up an awesome webinar series. And I thank you again.
Thanks, Bethany. I appreciate that, both the introduction and the kind words. As Bethany said, I'm Katie Hathaway. She just sort of told you my bio. For my visual introduction, I am a white female in my mid-40s. I have long, straight brown hair, brown eyes, wearing a very bright pink jacket today that looks orange on screen, but enjoy either pink or orange, however it looks for you. And let me introduce you to the rest of the panel today. You just heard from Bethany Hamilton, but I'll tell you a little bit more about her. Bethany's the co-director of the National Center for Medical Legal Partnership at the Milken Institute School of Public Health at George Washington University. She has a unique understanding of healthcare and legal services operations and the challenges and opportunities inherent in each. Prior to joining the National Center, she served as Deputy Director, State Affairs at the National Association of Community Health Centers. And she began her career as an Equal Justice Works AmeriCorps Legal Fellow at Legal Assistance of Western New York. In these roles, she built legal services capacity and led projects to expand access to healthcare, strengthening the ability of organizations to carry out their missions. As a member of the National Center's Advisory Council, she was part of a team that oversaw its transition to become a federally funded technical assistance hub for health centers. So thank you, Bethany. Sarah Huffman is another one of our panelists today. She is the managing attorney of the Medical Legal Partnership for Seniors Clinic at UC Hastings College of the Law. The MLPS Clinic partners with UCSF and the San Francisco VA Medical Center to provide free legal services to older adults in the areas of income and healthcare benefits, housing, legal planning for incapacity, and consumer issues. Sarah handles her own clients and supervises staff attorneys and clinical students. She also serves on a multidisciplinary consultation panel for VA system patients with highly complex medical and social needs, and regularly provides health law related trainings to medical providers and community organizations. Sarah founded the Veterans Project MLP Partnership with the San Francisco VA Medical Center at MLPS in 2015 through an Equal Justice Works Fellowship. Welcome to Sarah. Abby Nerlinger is a pediatric hospitalist at Nemours AI DuPont Hospital for Children in Wilmington, Delaware, an assistant professor of pediatrics at Sidney Kimmel Medical College at the Thomas Jefferson University. Dr. Nerlinger has experience in legislative and community advocacy, specifically in the areas of pediatric environmental health and healthcare finance. Her current research focuses on health system community partnerships, specifically measuring health and economic outcomes associated with medical legal partnerships. During her pediatric hospital medicine fellowship at Children's National Hospital, Dr. Nerlinger led efforts to develop evaluation standards for medical legal partnerships. She's currently overseeing the creation, implementation, and evaluation of the first pediatric-focused medical legal partnership in the state of Delaware. So welcome to Dr. Nerlinger. Caroline Wick is a practitioner in residence with the Disability Rights Law Clinic at American University, Washington College of Law. There, she teaches and supervises students who represent clients in a variety of matters related to disability law. She also teaches legal ethics. Previously, she worked as a senior attorney at Children's Law Center in Washington, D.C., where she worked in the CLC's Medical Legal Partnership and was the lead on-site attorney at a community-based medical center. She managed a caseload of 30+ patient families, representing clients primarily in the areas of special education, housing conditions, public benefits, and access to healthcare. Welcome to Caroline. So those are our panelists today. Before we dig into the conversation and the discussion that we want to have, a quick note: Bethany referenced office hours that I am doing. If you have questions that pop up after the presentation today that you would rather ask one-on-one, or just anything that you've been thinking about on this topic, please join me. I have 2 sessions planned after today. The next one is on Thursday, June 23rd. And following that, if there is sufficient interest, I will do the final one on Tuesday, June 28th. Both of those will be at the same time as each of these webinar sessions, which is 2 o'clock to 3 o'clock Eastern time. There is a link here to register for these office hours, which really just allows us to see any questions in advance, provide you with the Zoom link to participate. And I'm going to ask if perhaps somebody from the National Center could just pop this link into the chat box so that you can register now if you want to and participate. So what are we going to talk about today? Today's really is, as Bethany said, is sort of the culmination of what we've been building to. We've talked a lot about the substance of disability law. What are the legal protections? What is the health center and medical professionals' role in helping to address disability discrimination? What are some of the resources that you can consult? And just sort of how to navigate that. And today we want to talk with the wonderful benefit of people who have worked in a medical legal partnership. And we want to talk through some of the day-to-day, some of the operations, some of the strategies. What does it look like? So in a minute, I'm going to turn it back over to Bethany, who will do a little bit of some medical legal partnership 101. We're then going to talk about building. What does it look like to build a medical legal partnership? What makes it different to focus on or to include disability and chronic disease? Where might you build such a partnership? What are some of the strategies for building? And when I say building, I also mean growing or expanding to include this topic area. And then who are some of the potential partners that you might think about working with to either build or expand a medical legal partnership? We will talk a bit about some of the resources that are available. And then as we have for each of the others, there will be an open and available question and answer period at the end. So jot down your questions as we're chatting. Feel free to put them in the Q&A box, as we mentioned, but also if you'd like to ask them, we can get to them at the end during this open question and answer period. So with that, I will turn it back over to Bethany.
Thanks, Katie. So before we hear from our MLP practitioners, I wanted to do some very, very quick level setting. Before I do, I'd like to note that the National Center for Medical Legal Partnership has a health center MLP toolkit. It will be shared in the resources at the end and in the slide deck, where you can find out not just a definition of MLP that appears on the screen, but also step-by-step how to build a medical legal partnership. Our team also just put a link directly to the toolkit in the chat, so feel free to copy and paste that, open it up, download it, bookmark it on your browser so that you can access it frequently and often. For those of you who are building MLPs, outside of the health center context, we do find that quite a bit of this information, if not most of it, is applicable across different healthcare settings. So we encourage you to, again, download it and utilize it for building your MLP with a health center or without a health center. When we talk about building an MLP or medical legal partnership, what we are talking about is really applying an approach where this intervention brings together legal and healthcare professionals to collaborate, to be able to help patients resolve their social or economic or environmental issues that have those legal underpinnings and contribute to the health disparities, but may have that remedy in civil law. We're beginning to see that the models are evolving. In fact, later this month, the National Center is going to talk about a model that actually partners with a public defender's office to be able to address legal needs that present in criminal justice settings. But as this model evolves, it still retains these essential factors where you have the collaboration rather than the adversarial nature where these two professions would stereotypically be thought of interacting. You have a collaboration where people are coming together to address those health-harming legal needs of patients. How and what do they get done in medical legal partnership? Let's go to the next slide. If you've already downloaded our Health Center MLP Toolkit, or you've been to our website, or you've viewed our webinars, you will recognize what appears on the screen. We like to refer to it as our pizza pie slice, where we are showing a spectrum of activities that MLPs engage in. So by embedding lawyers as members of the healthcare teams, MLPs are engaging in legal assistance. That's the direct legal assistance to help those patients resolve those individual or family issues that are harming their health. They also go beyond that into trainings. So you have lawyers, for example, helping those CHWs or staff that are engaging in enabling services better understand how to screen for the social needs or legal needs of patients and make them able to refer out to legal specialists in the community. Medical legal partnerships also engage in clinical level changes, working together with their clinical partners to look at practices that may be carried out in a clinical setting and how they can work together to address broader patient populations' needs all at once rather than through the one-on-one direct legal assistance. And then finally, going up the stream to more systemic changes. Medical legal partnerships around the country are also engaging in policy level strategies and changes, such as looking at administrative barriers or regulatory changes, or even legislative policy changes that can be taken to address entire community health or population health. Ultimately, the results of these activities, we see outcomes that result in healthier patients. We see outcomes that help to improve and strengthen the health center workforce. And we also see improved health equity. If you're looking for more information on the impact of MLP, we do have studies on the National Center's website, in addition to the tools about how to build it. The best folks to explain exactly how to build the medical legal partnership are the practitioners in the field. So with that, I really did want to be very brief and in terms of explaining and what an MLP does and how we define it, and immediately pass the microphone back to Katie and our MLP practitioners to show you how they're getting it done and allow you the opportunity to ask them more questions. Katie, that's it. Pass it back to you. Thank you.
Thank you. So let's talk a bit about building an MLP that either focuses on or includes disability and chronic disease. Like what's different about that? Where would you build it? What distinguishes that? I think it's important to remember that, or consider sort of the recurring nature of a condition's role in and the impact on various aspects of life. So the nature of disability and chronic disease discrimination is that it itself can be ongoing, chronic, you might say. That doesn't mean that discrimination happens ceaselessly, but it is something that may come up many times, or various situations that could use some legal intervention that may affect medical outcomes, could come up more than once in a person's life. Your patients and clients just may need help navigating multiple scenarios over the course of their disability. For example, I'll use a diabetes example. Perhaps a child is diagnosed with type 1 diabetes in childhood, and they are still a minor. They are adjusting to their diagnosis. They need somebody who is available and trained to provide diabetes care to them while they're at school. And perhaps the health center and an MLP has an active role, as we discussed in a prior webinar, has an active role in supporting and helping them be safe and access an education. And then perhaps, they get to be their teenage years and they need some help getting their first driver's license, whether it's providing medical documentation or intervening in some way to clear up some sort of mischaracterization or misunderstanding about the safety of a person with insulin-treated diabetes operating a motor vehicle. Perhaps then that young person gets their first job and needs some help navigating the workplace. What reasonable accommodations do they need to manage their diabetes and work? Then perhaps there is a need for accommodations on a standardized test or in their college or university program. Then perhaps they graduate, whether it's college or graduate school, whatever it may be, and they enter a profession or they gain a full-time job. And the accommodations that they need in that field or in that career maybe are different than the ones they needed when they were in high school and had a summer internship or an hourly job. The workplace may operate or look differently than it did in their prior experience, and they also need some help navigating that process. Hopefully at that point, the patient or the client has some knowledge and some confidence on how to advocate for themselves, but it doesn't mean that it's always easy or without its barriers. And so an MLP can help at many different touch points in that client's life. There's also, I think, important to know what I consider are called sort of disability adjacent medical legal partnerships. And these are probably those that serve certain populations or those that focus on a specific issue. And it's possible to sort of flesh out the role of disability in those existing MLP structures. For example, and I know that our panelists have some experience on some of these structures, but a lot of older folks have some mobility or hearing or other age-related disabilities that impact them. Many children have food allergies, learning disabilities, other chronic diseases like diabetes, like asthma, which may require assistance both because they are a child and because they are chronic. And they may cause the kind of complexities that we've talked about in some prior webinar series. Disability can also arise in the middle of other life situations. We talked 2 weeks ago about COVID and long COVID and the role that those are playing in the workplace and in schools and in immigration detention settings. So there's a lot of places where right now COVID and long COVID are having a significant impact. People get injured on the job, and although the health center or a legal practitioner may not necessarily be assisting with a workers' compensation claim, it may be that there are long-lasting injuries that become disabilities and create a need for services or accommodations that didn't exist before that workplace injury. There may be environmental or climate impacts that cause people to develop disabilities. Sort of the classic medical legal partnership example of a person experiencing respiratory issues due to poor housing conditions. And sometimes the legal intervention clears up the medical issue, but sometimes the medical issue lingers and also then creates additional disability challenges. Mental health disabilities can be, as we probably know, misunderstood or even underdiagnosed, but can affect a lot of different parts of a patient's life. And once either a diagnosis or an awareness or a treatment begins, that person often needs to navigate new challenges. So for example, in this space, I think about the impact of COVID on mental health in a number of different ways. The impact of gun violence, the impact of racism, and so many other things that can lead to mental health disabilities. So it doesn't have to be that a medical legal partnership is intentionally focused on disability for there to be a role for this kind of advocacy. And perhaps think about if you currently have a medical legal partnership, what sort of wraparound services, whether it's screening or resource sharing, can you provide to support all of these different social determinants of health? So I want to pose a few questions in this context to our speakers and let you hear from them so that you don't listen to just me talking, and because we have such wonderful expertise. So I'm going to pose some questions, hopefully very broad and open-ended, and allow our speakers to share sort of their experiences and their thoughts on these areas. And the first one I'll pose to both to Caroline and to Sarah, two of the attorneys who either are currently or have worked in a medical legal practice, a partnership. And I'm wondering if you can tell us a bit about your experience working in an MLP that serves certain populations, or what role disability had in your cases in your practice.
I suppose I could go first. So this is Sarah, and our MLP specifically serves older adults. And so all the folks we work with are 65 and older, although the vast majority of them are, really 70 and older. One of the specific things that comes to mind that is very unique, I think, to our population is the rising incidence of folks with dementia and other cognitive disabilities, and so that plays a very specific role in representing somebody who has cognitive capacity issues. And so, one of the things that we, always tell ourselves to remember is that, cognitive capacity isn't global. Just because somebody has memory problems doesn't mean they can't make certain decisions. They might not understand very complex things like getting involved in cryptocurrency maybe. But, if they are losing capacity and need to name somebody they trust to manage their finances or healthcare, they might still have enough capacity to say who is in their life, who do they trust, who do they want to help them in their lives. And so, I think that's one very unique part of serving older adults is that, for folks with cognitive capacity issues, we do have to be very patient-centered. Some folks have better cognition in the morning or in the afternoon. Maybe they can't travel because traveling is going to make them tired and then they're not going to be able to engage with us as well. And so we have to be very flexible and sort of put the client at the center of our representation to make sure that we're doing everything possible to give them the best opportunity to work with us and to get, kind of address the issue that they're having.
Excuse me, this is Caroline. Prior to working at the Disability Rights Law Clinic at American University Washington College of Law, where I am now, I worked at Children's Law Center in Washington, D.C., and I apologize, I didn't do my visual description. I'm a woman, I have brown hair, I'm white. My background is the American University Washington College of Law building, so that you don't see my living room, which is a bit messy. And excuse me, I'm wearing a black jacket and a white, blue, and black blouse. And at Children's Law Center, we work primarily in 4 areas: access to public benefits, special education, access to healthcare, and housing conditions. And so I think one unique aspect of working with children in particular is kind of the length of especially the special education cases. And that builds off of what Katie was saying at the beginning, where a student who has an IEP or who's trying to get a 504 plan at school, so who needs specialized instruction or accommodations at school, an attorney may work to get those services in place, but then school staff change or the child moves to a different school, and so an attorney may need to become involved again and again. And so a parent may work with 1 or more attorneys over the course of the time that the child is in school. Another, especially for our purposes, another distinction with other MLPs is that although a provider is providing care for the child, when the patient is referred to the legal side of the partnership, the client is actually the child's parent. And so that doesn't always pose a problem, but at times that's something for a provider to understand when making that type of referral. In terms of how disability plays a part in the types of cases that we handled, I spoke about special education and housing conditions. We often had cases where the housing conditions were exacerbating a child's asthma or other medical conditions. So those were the types of cases that we took. We also would have cases where, a family may live in public housing or some kind of assisted housing and needed an accommodation, and would work with the families to get those, which unfortunately could take a long time. So again, kind of speaking to the length of cases.
Really good point that having that both the expertise and the commitment of the partnership for kind of seeing it through on a lot of those issues that take some time or that might be recurring. So, Dr. Nerlinger, I'm curious what your experience is when you've worked in a medical legal partnership. What are some of the disability or chronic disease related challenges that you saw?
Sure. I guess I think about it not only in addition to difficulties related to building a disability or chronic disease related medical legal partnership, but also how we think about it through this process of screening, referral, intake, delivery of legal aid services, and then also follow-up. And one challenge we face as healthcare providers is how do you screen not only for the impact of health harming legal needs on health disparities, but also integration of screening for disability, as I know was addressed during prior webinars. And then also, how do you provide appropriate education to the healthcare team about this screening? So for example, at Nemours, we're doing enterprise-wide social determinants of health screening that's done through EPIC. It's using the EPIC social determinants wheel. And then from there, if there's a positive on the social determinants screener, we use the iHelp health harming legal needs screener tool. And so one of the challenges with all of these different screening tools, especially the providers are using it well child checks, for example, how can you integrate a disability or chronic disease screening tool into that to be able to appropriately recognize how those factors might be impacting health outcomes? And then in addition to that is sort of framing it as children with chronic diseases or disabilities are also at increased risk for health disparities related to social determinants of health, right? So all of these factors are not only compounding, but also synergizing. And how can we recognize that? I think the second challenge, which was mentioned by other speakers, is how do we dedicate legal resources in a chronic disease or disability focused medical legal partnership. So we know that when we're establishing an MLP, that comes with a certain amount of funding that can be used to fund a certain percentage of FTE legal aid attorney time from wherever those funding sources are coming. So whether that's through the payer, whether that's through the healthcare system, whether that's through grant funding. And when I was at Children's National working with Children's Law Center, we did find that not only do children with medical complexity have higher rates of health harming legal needs, but as mentioned, the data showed us that they used increased legal resources that we sort of quantified based on an hourly amount of time, and that also these children tended to represent to legal care. So not only have we heard that, do we see that subjectively, but data has shown us that in some of our studies. And so how can we account for that when we're designing a medical legal partnership? The third challenge, I think, is how can we communicate the impact of disability and discrimination on achieving equitable health outcomes to healthcare leadership or payers? How can we really quantify and assign value to this? I think in the healthcare world, especially when it comes to medical legal partnership, a lot of leadership is more commonly hears about cases, say, related to housing remediation for children with asthma. But when you're thinking about maybe disability in the school setting or special education services, it's maybe not as familiar or straightforward to assign value to the legal intervention that it comes with improved services or benefits under an IEP, say.
Yeah, I think familiarity also brings sort of confidence and how to navigate those, and that confidence, I would hope, can be transferred back and forth between the healthcare provider and the legal provider and the patient that is being served. I'm fascinated about the data that you mentioned, Dr. Nerlinger, and hopefully when we get a little bit further down, we can dig into that a little bit in terms of what you might be looking for if you're seeking to develop or build an MLP in this space. I do want to dig into this issue of data a bit. I think we sort of, and some of the strategies for building a medical legal partnership that focuses or includes disability and chronic disease discrimination. Stepping back a bit and thinking about data, I think we all know that stories are powerful and data can be powerful if it's deployed in the right way. And clearly the same is true in the medical legal partnership space. Bethany, I'm curious if you could talk to us a bit about sort of what kind of data should a medical legal partnership or the individual partner seeking to form a partnership be looking to have or to build a sort of healthy and thriving or growing partnership, or perhaps to seek new funding sources. What kind of data or stories should folks be searching?
Great question. And so for the healthcare partners or healthcare folks online, you've already heard, I think, our MLP practitioners refer to some of those screening tools. One of the very first questions that any MLP, beginning MLP, or one who's looking to expand or grow into a new area should be asking is, what are the social needs that we're going to be addressing for the patient population that we serve. And that does require looking at everything from the EHR as your data set to the specific social needs screening tools that you might be utilizing. Several of the health centers around the country are already using screening tools such as Prepare, that's an APCHO, MAC, and I think OPCA developed tool, and can be adapted to be able to integrate within an EHR. And then you're also going to look over at your legal partners in the community. And I also want to note that your other data sets that you should be looking at are what does LSC funded legal services look like in our community? So finding out where legal services providers are in the community, you should be looking at LSC's website. If you're looking from the legal side at where the health centers are in the community, you're going to be looking at the HRSA website for Find a Health Center. But specifically with regard to what I was talking about for building the MLP, if you're at that stage, on the legal side of the equation, you should be looking really at your legal needs data. So LSC's Justice Gap Report provides some additional updated information on the level of civil legal needs. Talk to your partners together because you're going to find there is a lot of unmet healthcare and a lot of unmet legal need. And you do not have to decide to take on every single health harming legal need and social need. So where do you start with your data sets? Look at the existing data sets that you have in the EHR and through the social needs screening tools that are already being utilized, and come together on deciding what consistently aligns so that year by year, as someone I think posed in the Q&A already, you are able to align and measure for the needs across both of those settings and see if you're able to meet them through your medical legal partnership year after year and have an impact along the way. So it's whether you're starting or you're sustaining, make sure you're looking at the existing data gathering tools that you have at hand. The EHRs, I think, are much more advanced than the legal case management tools that we have as legal services providers in our community, but they can be aligned to find consistent data points. The questions may not look exactly the same, but ultimately they may be getting to the exact same results, and then make sure you consistently use those data sets year after year.
Thank you. I'm curious, Dr. Nerlinger, from the provider perspective, I guess, are there certain data points or even, clinical outcomes, stories about those or data around it that you'd be looking for if you were approached perhaps to establish a new partnership, or that you would expect to see, I guess, in the course of a partnership proceeding to address these legal needs? What would you be looking for?
Sure. I usually put this into 3 buckets in terms of outcomes that you would want to consider when you're designing a medical legal partnership. The first is you want to show that the legal services that were provided are associated with a positive legal outcome. The second, that is definitely a priority to healthcare systems, is to be able to show that the legal aid services address social determinants of health successfully to be able to improve health disparities. And third is directly looking at the impact of legal service provision on health outcomes. And there are a few different ways that you can look at health outcomes. So I was working with the AAMC on a project called the AHEAD Initiative a few years ago, Accelerating Health Equity, Advancing Through Discovery. And this was a multi-institutional project where at Children's National, we had partnered with 2 other MLPs to look at to basically develop a standardized evaluation framework for medical legal partnership in the areas of community health, learner outcomes, and healthcare systems and savings. And as part of this, we surveyed healthcare leadership to see what outcomes they were most interested in. And a few themes emerged. If you're interested in more details, that paper is published and available online. I can try and post the link in the chat when we're finished. But the themes that sort of emerged as priorities for areas of health outcomes: The first is looking at direct cost savings. Oftentimes, this is done through a change or decrease in acute care utilization. So especially in a lot of risk-based contracts and moving towards more capitation with quality measures in terms of healthcare financing, that we want to increase preventive care and decrease unnecessary acute care utilization in the emergency department and inpatient setting. We know that especially in pediatrics, a small percentage of patients consume a large percentage of the healthcare costs and resources, and that many times a chronic disease-related medical legal partnership or disability-related MLP is really targeting these so-called healthcare super utilizers. So I think that's one important thing to keep in mind, is to being able to link referrals back to how they're using healthcare, and whether that's appropriate or inappropriate healthcare utilization. The second area is to be able to show compliance with well child care. So in pediatrics, specifically looking at compliance with well child checks and immunizations, because for many healthcare systems, these are requirements of their contracts with payers. In addition, it's also important to think about outcomes specific to different chronic diseases. So for children with chronic diseases or families with chronic diseases, this could mean thinking about how legal service provision impacts patient or family satisfaction with care, how it impacts well-being, how it impacts disability scales, measuring, say, ability to perform activities of daily living. So specific measures of chronic disease control include, say, looking at hemoglobin A1 scores level for children with diabetes, or a number of pain crises for children with sickle cell. So thinking about how some of those measures can be integrated depending on what chronic disease process you're focusing on. And then the third way to think about this is in terms of healthcare recovery dollars. So there's a dollar benefit that can be assigned to the amount of services that are attained through partnership with legal aid. So for example, if a child with a learning disability was able to access increased therapies or specific accommodations under a new IEP, there's a dollar value associated with this that can be used to show value of the MLP, and that health systems can also claim potentially under their community benefit dollars that are required to maintain their tax exempt status. So there's lots of different ways to approach value when it comes to MLP. Some of it depends on the healthcare contracts that the payer or healthcare system is engaged in, but it's important to think about that from the beginning because it frames how you're going to be doing the data collection.
Thank you for that. I think it's really useful to think about the data and the outcomes as more than just, or not just limited to clinical, but also the financing, the economic impact, the systems impacts as well, because depending on who the conversations are with, various data will appeal to various potential partners. So thanks for that. Let's dive in a little, talk a little bit more about some of these operational factors, I guess. You know, how it works, where it works well and why, and some of the things that I think are perhaps just as, if not more important, to the successful operation of a partnership than the actual legal or social determinants of health, but things like managing expectations, communications amongst and between partners and patients and clients. I guess I'll start with posing this to both Sarah and to Caroline from the legal practitioner perspective. What would you identify as some of the aspects of managing expectations, both between partners in a partnership, as well as between and among the patients or clients and their families or support systems who might be also interfacing with the MLP?
So this is Sarah Huffman. I apologize, I forgot to do my visual description earlier, but I'm a white woman with medium length brown hair. My background is a very plain office with a couple plants, and I'm wearing a black jacket, and I guess the color of my shirt is blue. I'd forgotten. So operational expectations with MLP partners. Honestly, I think the biggest thing is communication, open communication, and finding joint goals. So, at the beginning of our MLP, when we first got off the ground, we're a pretty small clinic. We're not a regular legal aid agency where everyone can come in. And so we have, limited bandwidth. And so just as an example, sort of one of the first operational things that we really had to, communicate with about and sort of work out was, what specific medical services was our MLP going to be open to in the health center? Because the health center is absolutely huge, and inpatient, outpatient, all this kind of stuff. And so, we, with our partners, we just sort of had these goals. What's the population we want to work with? What types of patients in that population do we want to target or specifically help? What types of legal issues can we help with, and where can we find these folks in our medical partners' healthcare system? And so, kind of working together, we were able to address this, kind of operational challenge of size, and figure out the specific medical clinics to work with where we're able to work with those folks, but we're not overwhelmed by the entire hospital system. I think another thing over time, with just having really good communication and relationships, over longevity, things do come up occasionally that, do have some kind of operational challenges. I think, one thing specific to working in a hospital setting. So we do now take a lot of referrals from a hospital setting. There are sometimes goals that don't quite align between the hospital and the patient, right? I'm not talking about malpractice, that's like a totally different topic. But just for example, we work with older adults, sometimes older adults with dementia, they might end up in the hospital for long periods of time. They might be stuck there for a long time. The word conservatorship or guardianship gets thrown around a lot, if you guys are familiar with the Britney Spears case. And so, the hospital, they don't necessarily want to have someone staying in the hospital for 300, 400 days when they don't need to be there. But from the legal patient advocate standpoint, we want to do the best for our client and whatever the client needs that's best. And so, in those sorts of periods of time, the goal isn't necessarily quite the same, but having the great relationships already between, the legal team and the medical team, it's really easy to work through those. The medical team knows that we're not the counsel's office for the hospital, and they know that we're the patient advocate, and just having those kind of open communications are really helpful. I think on the client side, as far as managing expectations, and Caroline kind of touched on this earlier when she was talking about working with families and children and parents, we do see quite a bit of that too with older adults. A lot of times older adults will take their family members, nieces, nephews, sisters, children with them to doctor's appointments. And so families are often really used to being very involved in any kind of care for an older adult. Not always, that's not always, but it does happen. And so as, on the legal side, we have to be, pretty clear in setting expectations. And, sometimes the family member can't be there. They can't be involved. We also have to look out for sort of undue influence, or, is this person a good actor or a bad actor? And, so we do have to set kind of expectations with the client and also with the family sometimes, obviously the client kind of being in the center. So that is one thing that does come up sometimes.
And just to build off of that, I think it can be helpful, excuse me about that, to communicate with providers and set expectations about when the legal side can accept representation or represent a client and when they cannot. And so I saw a number of times at the outset of the medical legal partnership with the site that I was at, where a provider would make a referral and it wouldn't work out for another reason, and they would feel disheartened and may feel, why should I do that again? Or I'm going kind of above and beyond to make this referral. It's adding to my daily work. And it didn't work out for this particular patient. So talking about, sometimes we can't assist because too much time has passed and that we can no longer file, or it's outside of our area of expertise, but we're going to provide referrals elsewhere. Or unfortunately, the law just may not offer a recourse. Or maybe we have a conflict and we can't accept the case for that reason. So providing, explaining that. A small thing, but on the just in terms of managing the partnership, I think it can be helpful, and we found it useful to set up a time for attorneys to join the provider staff meetings or the provider's provider meetings to give updates, just to say, hey, we're seeing that students or families are really having trouble with school enrollment right now. So if your patient is having those types of issues, you might refer them here, or they can call this number, that kind of thing. Or, it's winter time, and we're seeing a lot of patient families have trouble with heat. On the client side, excuse me, I think understanding, setting expectations about the difference between working with a doctor and working with a lawyer. So if a client tells me something, I can't, barring just a few exceptions, I can't repeat it elsewhere unless the client says it's okay. Or also understanding that working with me is voluntary. So, even if your doctor did refer you to a lawyer, you don't have to work with a lawyer. So understanding of course, we hope that they do, but understanding what it means to engage with a lawyer and what the representation will involve. And also understanding that both on the provider and the client side, sometimes client patients don't want to work with an attorney or don't want to seek legal redress for certain issues. So I'll leave it there.
Thank you. It sounds like, not to put words in your mouth, but just like a lot of other aspects of aspects of relationships, what I'm trying to say, that building and maintaining trust and being clear in both in your communications and shared goals and shared intent really go a long way. I'm curious, Dr. Nerlinger, if you have any comments sort of from the provider perspective of this aspect.
Sure. I was actually going to bring up similar themes to what was just mentioned in terms of open communication, the importance of that, and the importance of setting shared goals between the legal aid partner and the healthcare system. I think another issue rises that's especially important for providers, important to reiterate, and that these issues are very sensitive and personal to families. And I think many providers feel like they have very good relationships with patients that they see regularly, but some of these issues are still so sensitive to the point where they just don't want to talk to a healthcare provider about them. And it's not that they don't want to talk about the issue, it's that they don't want to talk about it with their healthcare provider. And this is, in certain communities coming from years and years and years of built mistrust around healthcare and healthcare providers. That part of the role of MLP is really breaking down some of those walls to rebuild trust with the community. But we know that, for example, with our social determinant screener, although we have a significant percentage of families in certain zip codes that identify positive social determinants of health on their screeners, that significantly less than 50% actually want help to address those needs. And so it's really important to keep that in mind. And it's also important to keep in mind that, families know that healthcare providers are mandatory reporters for child abuse and neglect. And so sometimes there's a certain amount of suspicion that accompanies disclosing, say, food insecurity that could, on the healthcare provider side, really be perceived as neglect if it's not interpreted correctly. So that, one role of referral to legal aid is, like was mentioned, that sort of client-lawyer relationship and the confidentiality surrounding that. And maybe it's easier for families to discuss with that relationship.
Really useful point about the mandatory reporting. This is something that we dealt with in the diabetes space with laws that sought to require mandatory reporting by providers for driver's license issues. So it comes up in a lot of different contexts that you may or may not anticipate and can breed some distrust or just wariness, I guess, of that relationship. So in the interest of time, I could talk about, or we could keep going into this, but I want to move on into some of the other operations. And I think we've, in various places, have touched a little bit on sort of the how and the where of these kind of partnerships, the pros and cons of different structures. There are some medical legal partnerships where the legal practitioner is on site and some where they are not. Just one example. And I also want to talk a little bit about some of the other benefits of bringing, and I think Caroline just touched on this, but some of the other benefits of bringing the legal practitioner into the medical care team and the operations of the medical care team. So let me start by asking Bethany, sort of, if somebody is listening today and they want to start up a brand new medical legal partnership, where do they start? What are some of the conversations that they should be having?
So if you are on the healthcare side of the equation and you are the healthcare clinician or operations or administration staff, or especially in leadership, and you're thinking about starting a medical legal partnership, one of the first things I would recommend that you do is reach out to the legal services providers in that community. It's really important, as others have already expressed, that you find out exactly what they work on and where they are. For those of you who are in rural areas, you will find that there are legal deserts, just like there are rural hospital deserts, right? And you may not be able to bring in person a legal services provider, but we have seen as a result of the pandemic that there are ways to still deliver civil legal services without having to be in person. Kudos to the healthcare providers around the country who have been fighting for years for telehealth. And we now see that the delivery of telelegal is also possible and should have been done as well a long time ago. But we also know, flip side of the coin is there's a digital divide, right? And that has played out in urban communities as well. So let's say you are in a community where folks can meet in person. And let's say maybe you're the legal partner and you're trying to partner with, or you're a legal services provider, excuse me, and you're trying to partner with a healthcare partner. This is where you're really going to want to find the healthcare champions. It can be a clinician, but if that clinician is not the CMO and may also need to speak with a leader, someone who's leadership in place and can ensure that that partnership that you're trying to form can sustain well beyond changes in staffing or changes in terms of the needs of the community or changes in terms of the funding that's available, you're definitely going to want to find your healthcare champion. The civil legal services providers around the country have been addressing these legal needs. And it's just really important to be able to find that healthcare champion to help build a long and sustainable, lasting infrastructure. Because you don't want to offer these services and then 2 years later or 3 years later, when funding ends, have to deal with removing that service from the community. Beyond that, I would just be really, I just want to reemphasize that the points we made about, tracking of data. In 2016, the National Center for Medical Legal Partnership did talk to the MLP community, the practitioners, and they looked at the literature, the research and the studies that had been done to be able to come up with some initial performance measures. But I'm bringing this up because I want to note that those who are in the legal services space, as well as the healthcare space, especially the health centers, may not have the capacity to conduct evaluations. So where else do you start? I would also certainly reach out to the academic community and see if your universities can be your partners in developing evaluations, conducting the research, helping you to collect and align data along the way. So it's the where else do you start? We've identified the M and the L, the medical partners, the legal partners, but there's this other partner that plays a critical role in starting and sustaining a medical legal partnership. And I do think that is the research community, and universities and academic folks are there to help. We do have examples, and in the chat, I will paste a link to the 7 initial MLP performance measures and how to use them. That's the guide that NCMLP put out in 2016.
Thanks, Bethany. So that's sort of the beginning stages, I guess, or the factors to assess and to discuss at the outset of starting or expanding a partnership, an MLP. I'm going to pose this question to the other 3 panelists, sort of what are, in your experience, some of the pros and the cons of the legal practitioner being located on site versus an external location. And I'll just reference that Claudia has submitted a question about sort of the best model to provide an efficient service just based on the referral model or having a legal office in the hospital. So I'm really curious from each of your perspectives, what works, what doesn't work, what are some of the pros and cons of those two scenarios, those two setups.
I can go first. So I think there's a good article from the National Center as well on data sharing and medical legal partnerships. And it describes sort of the different models of data sharing, anything from having a legal aid attorney off-site to having an attorney on-site and having the attorney actually document directly in the electronic health record. I would say, having the attorney on-site and documenting in the EHR really is the gold standard, because I think everyone would probably agree that that's the true model of partnership. I think this is the case for a variety of reasons, just from a workflow standpoint, the HIPAA authorizations, medical record releases, consents if you're doing research, all of that is much easier if the lawyer is on site and available to meet the family or client directly after their healthcare appointment. I think it also allows for a smoother transition in terms of potentially a verbal handoff as well. And in theory, you'll probably see an increased rate of legal intake after referral from the healthcare partner if the legal aid attorney is located on site as well, because that's often an outcome that MLPs are tracking too, is what is the actual rate of intake after the referral is made. That gets a little bit more challenging when the referral and legal aid attorney is located off site. I would say, off-site, it was mentioned a little bit in terms of telehealth services and virtual opportunities. And I definitely agree that especially within Nemours, our telehealth expanded exponentially as a result of COVID, which has been great for many families, especially families with chronic diseases and disabilities, like, for example, our patients with cerebral palsy and ventilator or G-tube dependent who might have difficulty coming to appointments frequently because they have to move all of their equipment, all of their wheelchairs to these appointments. But I think important in that, and we touch on this too, is that if the telehealth opportunity is there, we also have to make sure that there aren't disparities in access to telehealth services. One of the most commonly reported needs that we see on our social determinant screener is access to reliable internet. So thinking about that as you're thinking about offsite and use of telehealth and legal services as well. But again, the flip side is that the telehealth can help address transportation issues. So another significant social determinant for many of our families. In Delaware, we have the north is very industrial, the south is very rural. If we say, as Nemours, which is the main children's hospital in the state, had 2 FTE attorneys to dedicate, my guess is that those legal aid attorneys would probably be located in the north, and it would be geographically difficult to have attorneys at all of the sites, the clinic sites in the south, just because the population is less sparse. So being able to have attorneys off-site from that standpoint, you may more easily be able to target patients who live in rural areas.
Yeah, I'd like to say from the lawyer standpoint, being on site is absolutely fantastic. I mean, being able to catch patients, you sort of, a patient's having an issue, they present to their doctor, the doctor's like, hey, there's a lawyer down the hall, let me just walk you over and introduce you, and just see what they say. Being able to have access to folks in that particular way is a very unique and special opportunity. And that, sort of relationship building with the providers also helps in that particular, setup. It's also great for patients who, they're already there. Maybe they did have a difficult time getting to the health center in the first place. And so, having to make a separate appointment to go to a lawyer's office, that's intimidating and it could be difficult. And, so I think that does help with the trust building with patients, clients, because, a lot of times patients, clients, they don't trust lawyers. They're like, lawyers are expensive, we hear all kinds of crazy things about them, they're shady, but most people, not everybody, but most people, do trust their primary care doctor, or at least to some extent. And so to have that sort of warm handoff between the two is really helpful. Specifically in working with older adults and folks with disabilities, though, I think it is important to be flexible. So initially when our clinic first started, we were on-site at an outpatient clinic. And then we sort of, over time wanted to start focusing on and reaching folks who had more complex issues. And so, because of that, we decided to start going into people's homes and start working with the outpatient or the home-based primary care programs and the hospital programs. And so for us, it was really important to be flexible so that we could do home visits for folks who couldn't even get to like their doctor's appointments. Or folks who had very severe mobility issues, or just couldn't get to the doctor. So I do think it is important to be flexible, to be able to see patients and clients where they are in that realm.
Yeah, particularly important when this population that we're discussing today is those that live with various conditions and maybe multiple conditions, one of which may impact their ability to be physically present. Caroline, any other comments from your experience?
Echo everything that's been said. I think another added benefit is the lawyers can then also do direct outreach to the patients. So for example, we used to do patient pop-up trainings where we would go to the lobby, we call our lobby trainings, and we would go to the lobbies and say, it's back to school time and here's some things to think about. And are you interested in talking to a lawyer? And we would get a number of referrals that way, or or patients who expressed interest. I agree that it's wonderful to be able to make the direct referrals and to be available for consultations. For the legal provider side, really working with attorneys to make sure that they can kind of block out time to be available, and that they're not, if they're on a filing deadline or have a virtual meeting scheduled, sometimes they're not always available. So again, it's setting expectations for providers that the attorneys are not always available, right? Even if they're on site, they may have conflicts, which is, so just being clear about that.
I'm going to sort of just use my prerogative and jump in because I think there's a relevant question here in the chat box. But if you have any thoughts about this, Sharon has asked, how do medical and legal providers share resources and tools to support the client? She used as an example interpreters and I think physical space. Any thoughts on that?
So physical space, we have a license to be on site at the medical centers that we work with. And, we work with the particular clinic about days or times we're going to be using a particular room. So we're kind of assigned a room. As far as resources, interpreters, we do have access to the health system's interpretation line. So if we need to use that, that's available, which is really a fantastic resource that the medical center has provided for us. And, as from the legal side, we actually do provide a lot of resources and informational resources to the providers, the medical providers, the social workers about relevant sort of legal things. I know we're going to talk a little bit about a different topic later. And so I think I'll bring that up again.
Okay. Any other comments? Or and maybe just to extend this, I think when we talked about sort of the electronic health records as one resource that gets shared, and so obviously like the referral or the provision of legal services to a patient or a client, those are very specific and defined and probably expected, both sharing and roles. But I'm wondering if you all have experience sort of with legal providers having roles on site or not on site that go beyond sort of client legal assistance. I mean, Caroline was talking about the pop-up, and that to me seems to place a high importance on training, both of awareness and training, both of the patients or clients as well as the other medical providers. So are there any roles that you've seen that go beyond maybe what's expected, so that these are an attractive thing that you can achieve by establishing a medical legal partnership?
I think it's important to also highlight not only attorneys' roles in training providers, but also training medical trainees. If you look at medical student residency curricula, that a growing part of that is related to advocacy, social determinants of health, health equity. And so definitely any trainings related to MLP are going to reinforce that curricula as well. And then I think the last role is thinking about lawyers as in their roles as legislative advocates. And I know this was mentioned at the beginning, but in terms of regulation, advocacy, there's a great example from Children's Law Center where the MLP was able to recognize that mold was impacting health outcomes for many of their children with asthma, but that mold was not part of DC's list of housing code violations. So they were able to, through legislative advocacy, or I guess regulatory power, you guys can probably explain that better, it was added to the list of housing code violations, so then it could be enforced by the legal aid attorneys to help improve health outcomes for children with asthma. So in my mind, that's sort of going above and beyond, and those partnerships with government relations to think about how healthcare systems are approaching legislative advocacy are very important to healthcare systems as well.
Really good point. Systems advocate. Yeah, sorry, Caroline.
Oh, no, just in terms of sharing resources, you know, if oftentimes providers would reach out and say, you know, I know you can't represent a client with respect to this family law matter, but could you provide me resources? So I would send, you know, if the patient had called us directly, this is the list of resources that we would send, but the provider could provide it directly. And then also, you know, one of the nice things about being on site is also identifying other legal areas where providers are seeing that their patients need assistance. So when I was at the health center, a provider said, you know, I'm just really seeing a lot of employment discrimination cases. So we did we worked with a different organization to do an employment discrimination training there. So those can be other types of resources that are shared. And beyond legal resources, you know, just providing information about public benefits or other resources that are available to patients.
Wonderful.
Oh, I was just going to say we do a lot of formal trainings on different things like, you know, Medicaid and stuff like that. And then I was going to say the sort of the reinforced learning between both the medical providers and the legal providers, where over time, you know, we learn a lot from the medical providers. If we have a case that has, you know, a medical component and we don't know how to kind of read the medical record, you know, being able to sort of have that resource to go to the doctor or the nurse and say like, hey, can you give me a sort of layman's terms of what's happening here so we can, you know, represent our patient. And so I think just having that kind of continuous reinforced help and resources, either sort of formal or informal back and forth is really valuable.
Katie, I just want to add one other thing. We're talking about sharing resources, but you know, the MLPs have also been able to show that they also save resources, right? So they are actually able through their work to save on healthcare utilization where it might be where it would have been unnecessary, right? Saving from folks going into the ER and EDs. Or being admitted because perhaps through preventative legal advocacy, they were able to get someone covered and into primary care settings rather than more costly settings, or they were able to get someone coverage for a medication or get into WIC programs because they were able to address an administrative barrier and prevent the health harms that lead to higher cost for families and for entire systems. So speaking of sharing of resources, they're also helping to save on resources that would not need to be utilized in the way that they would without an MLP.
It seems to echo what Dr. Nerlinger was saying earlier about sort of some of the data and the outcomes and you know, completes the circle to some extent. You look at it at the outset and the initial discussions about establishing a partnership, and then how does it play in the continuance of that partnership. So really important point. So I'm going to move on to sort of talking about like selling the partnership, and I say selling in a really loose way, but who are your potential partners? And And Bethany has talked about this a bunch on sort of the legal services LSC funded organizations and legal aid organizations that are in communities. I also want to mention, and it's been mentioned throughout this series in a few different times, both directly and through some of our presenters who have represented this system, that if you're looking to build out or really specialize in the area of disability rights, disability law, that you should consider conversations with your state protection and advocacy organization, otherwise known as the P&A system. And they really are probably the foremost experts, and they will have a lot of knowledge about disability law and disability issues in your particular community, either on a state level or a community level. But they are a federally established and funded system intended to protect and advocate for the rights of individuals with disabilities. So they are, let's see, I think I have that listed here, yes. They are going to be a really good resource, whether or not it leads to a specific partnership. I think it's really helpful to know these protection and advocacy systems, know who it is in your state and get connected with them. So some partnership, potential partner questions that I want to dig into here. I'll start direct this question to Sarah. What's your experience? What is it like when you're establishing a partnership with a law school? Any pros or cons or any tips that you might have?
Yeah, I think there's a lot of pros for sure. A law school is an existing infrastructure, that has student clinics. So not all law schools have student clinics, but most do. And so, the school is already used to having, a clinic that both teaches students and also provides services to the community. And so having the infrastructure already there, and also along the same lines, it's a source of funding, right? So you have a faculty member who's going to run this clinic, and the funding for the faculty member comes from the law school. And so, that's definitely a great pro of having a setup at a law school. As far as cons, the only thing I can really think of is, in having a service clinic with students, the only issue is going to be bandwidth and speed, right? It's not going to be a clinic that's going to be able to serve thousands of people. So the number of clients you're going to serve is going to be a little bit lower. And students aren't going to be able to handle tons of cases. And they're also learning to serve this population. And so they might be a little bit slower in kind of getting certain things done. And so, if it's probably not the best setup for absolute emergency situations, but if you have longer term cases or cases that don't require some legal intervention within the next 2 hours, law school is going to be a great place to set up an MLP clinic.
Caroline, I'm curious, I know that your experience is not at your current law school is not in a MLP structure, but what you might add to that, I think about also just the change of semesters and the change of students, whether that goes to bandwidth, to Sarah's point, or maybe the ebb and flow of casework. Any comments that you might like to share there?
Certainly, if as you're establishing the MLP, you might talk to the the law clinic and ask, is it a semester clinic? Is it a year-long clinic? What kind of support do they have over the summer? So I support the cases over the summer, but at other clinics, they might have students that help out or multiple students, just kind of assessing what the bandwidth is. And then to Sarah's point, just getting a sense of how many cases could they take. It might make sense. It might make sense to also partner with other legal providers depending on what your goals are. And then also talking to them about what types of cases they may be able to take. Law students are wonderful, but they're just learning the law, so they may not be able to take the more complex cases that a legal services provider with more attorneys available might be able to take.
Caroline, I'm curious, to my knowledge, there are both your clinic and others that do really focus on disability rights. Are there enough of those around the country? Or should folks look broadly to law school clinics, recognizing that they might do a lot of legal, civil legal services that may not be specific to disability? And then there are those like yours and others that are very.
I think that's a great point. I think medical providers should look broadly and not be discouraged, or, for instance, medical providers might reach out to us with a case if we can't take it for one reason or another. My law school also has a gender justice clinic and a civil advocacy clinic and an immigrant justice clinic, many other clinics that may be able to take similar cases.
Lots of resources. Dr. Nerlinger, I'm curious from your perspective, from the provider and medical clinical field, is there a role for sort of specialty hospital practices to have medical legal partnerships? And I think about some of the conditions that are pretty regularly referred to specialists for care, pediatric endocrinology or oncology or allergists, for example. But if on the flip side, if a legal services provider is seeking a unique or just an opportunity to expand their partnerships, should they look to hospital specialty practices?
Yes, definitely. I mean, if you're thinking about chronic disease, law, or disability, that specialty clinics are going to, be a medical home in addition to a primary care medical home for many patients with chronic diseases. For example, Katie, you mentioned a few, but in a hem-onc clinic, children with sickle cell disease or certain cancers, children with congenital heart disease is another population that comes up a lot. And then patients with diabetes, and then also thinking about mental health and psychiatric care within the healthcare system and where that's delivered to, and if that's a potential for a partnership. And then specifically at Nemours, we see a lot of patients in our orthopedics clinic. We have a cerebral palsy specialty center. So that may be another place where on the legal side, you would think about partnering. In addition, just to suggest a couple other clinical settings that might be appropriate for partnership, more and more healthcare systems are partnering with schools and school-based health centers. So thinking about the potential for partnership with school-based health centers. And then additionally, there are just such interesting programs going on throughout the country with data sharing with schools. Nemours has a program we have set up where parents have consented to allow the school district to share absenteeism data with Nemours so that our case managers get reports of absenteeism data and could potentially direct community health worker services or tiered case management services to direct those patients who have been missing a lot of school. So thinking about a role of medical legal partnership, for example, if we know those children have asthma and they've been absent from school, should they be referred to MLP? And then the last setting that I think is not necessarily a partnership, but a clinical setting to think about is the inpatient setting. There isn't a lot of data around MLP in the inpatient setting, but there is more and more of a push, especially in pediatrics, to screen for social determinants within the inpatient setting. The argument being that patients who are in the hospital may be these sort of healthcare super utilizers that are coming to the hospital frequently. They're readmitted prior to even being able to follow up with their pediatrician. So they never get the chance for that MLP referral because they're just always in the hospital. Or patients that are lost to follow up in the outpatient setting for a variety of needs. So thinking about setting up referrals from the inpatient setting and then what resources that would entail once that's set up.
Yeah, it seems like there's a lot of opportunity, if not a partnership with all of those different aspects of the hospital-based or setting, that there is a lot of rich resource to explore what the hospital-based setting is identifying as some of the potential problem areas and take a systems approach to solving it.
Yeah, and just to add as a follow-up to that, it's really thinking about how health harming legal needs are impacting the health outcomes of interest for that specific population, because there's going to be a limited amount of resources when it comes to legal aid services to achieve a specific goal. So thinking about how those services can be delivered in the highest yield or highest sort of return on investment manner based on what the goals are of the partnership.
Right, to your point earlier about working in DC on the housing code. That's more than one client or patient and one problem. It is a whole system that gets changed as a result of identifying that issue. Bethany, on this idea of partnerships and with the MLP model, who initiates the partnership? Is there a sort of standard way of doing this? Who starts?
Yeah, I don't know if there's a standard anymore, but I would like to say, kudos to the physicians, all the way back to Dr. Jack Geiger, one of the, founding fathers of the community health center movement, who recognized that it was the lawyer in the community who could really address those health harming legal needs of the patient population in Mound Bayou, Mississippi. Fast forward right to the 80s during the HIV/AIDS crisis, where folks in DC, such as Whitman Walker Health, really recognized the role that lawyers could play in helping to address, that chronic disease, disability, deadly crisis around the country, and what role lawyers could play in assisting patients who were dying or needed guardianship and other assistance, especially as we're talking about discrimination issues in this webinar series. And in the 90s, we saw, really the lawyers and the pioneers of the current traditional model that we know, Ellen Lawton, Liz Tobin Tyler, Samantha Morton, and the others, partner with their, the Megan Sandals and others in the healthcare space at the hospital, children's hospitals in particular, really led, I think, the development of traditional MLPs. But, who's starting the conversations? Let me just recognize, especially given a question that came up in the Q&A, the role that the social work community has played and those who are CHWs and working on outreach and enrollment to really talk to, because they are trusted. And they're talking to the patients or clients that we all share in medical legal partnership and other health justice partnerships, and have just needed these partnerships to be formed and the silos to be broken and taken away to be able to not just screen for, but refer those individuals to an actual provider in the community and be able to track the outcomes of those referrals. So there are a lot of people involved, and with the evolution of the partnerships, the conversations are starting in new and awesome places, including our legislative representatives. They're having conversations about how to advance more medical legal partnerships. So I want to recognize that as well.
Thank you. So I'm going to just wrap this up with sharing a couple of resources, letting you know where you will see more. And if there are questions that you haven't asked yet, now is the time to pop them in the Q&A box. Or if you think of them afterwards, the office hours are a really good opportunity to ask that question. Like I said, June 23rd, June 28th. On this slide, there are 2 screening tools that have been created for this series, and recognizing that from the provider side, and I think Dr. Nerlinger could probably confirm this, I can't speak for you, but I'm guessing that you don't need any more things to be added to your plate in terms of patient questionnaires and surveys and all of the different ways that you do current screening opportunities. But these are intended to be concise and quick and simple ways based on sort of different categories. So there's two screening tools here, one for adults and one for children and young adults. But a few questions in some different sort of bucketed categories that could be built into current screening tools. By all means, these can be modified. These are hopefully intended to be useful and not a burden. They are going to be included in a publication that will come out from this series and should be available later this summer and posted on the National Center and Health Outreach Partners websites. You will have access to it. These are part of that. That publication will have sort of the top line takeaways from each of these webinar series, some of the legal protections, the role of the health center, some of the key things that you can do in the employment discrimination space, in the education and related places of public accommodation, in the immigration, detention, and custody settings. And it'll have all of the resources that have been mentioned throughout this whole series. And if you've been participating, you know that there have been a lot of those, both today and in the other 3 sessions. So that is, those are some of the resources that we wanted you to have today. I know that there's been some other comments and questions that have been popped in here, and we will take a look back at those comments and questions that you have typed in and see if there are some resources that we can provide in response. But I want to take this opportunity and thank you for participating. I don't see any additional questions that I think that we haven't addressed or that we could address today. So I want to thank you for joining us. This was the last webinar in this particular series. We hope to do a follow-up in the future. As Bethany mentioned, on the National Center for Medical Legal Partnerships website, which is listed here on the screen, medical-legalpartnership.org/resources is where the recordings with the slides of the prior 3 webinars are already posted, and this one will be posted in due time, as well as the publication that I referenced. So any closing comments, Bethany, before we close this out?
I just want to, in addition to sincerely thanking you, Katie, also thank all of our MLP practitioners who stepped away from their day-to-day work today as clinicians and civil legal services providers to present to those of you around the country, and also to those of you who tuned in. We thank you very much as well for tuning into today's live webinar, and take a look back at the previous 3 webinars, and don't forget to fill out our evaluation. Thank you to Health Outreach Partners for partnering with us. Those of us here at the National Center for Medical Legal Partnership look forward to seeing those of you on the office hours so we can continue to provide you with assistance so you can build and sustain your medical legal partnerships. That's it. Thank you, Katie. And thank you to our ASL interpreters.